Hello everyone. Today in the case series, we will deal about chest pain. So whenever an individual presents with chest pain in casualty, all of our major concern will be to rule out myocardial infarction. So whenever there is case of chest pain, we have to deal in this manner. First is, in history, there are few things which we have to focus. For example, we have to ask the duration of symptoms. First is duration. So if the individual tells that the chest pain is sudden in onset and it is of very few minutes to few hours duration, that is very, very important in concern to myocardial infarction. So sudden onset and lasting for few minutes to hours. We have to consider here possibility of myocardial infarction. Whereas suppose the duration is of some days and it is like on and off they are getting, and as I told, it is lasting for few days. So few days or more, then we can take some time because it might be due to other causes. This is about duration. Next comes the location. So we have to ask the individual to locate the chest pain using a finger. If the individual is able to locate, like localized, if it is localized, then we can consider other possibilities here. Because the chest pain, suppose the chest pain is due to myocardial infarction, often individuals will not be able to pinpoint it using a single finger. That is, in myocardial infarction, usually it will be diffuse in location. They can't easily localize it. So here you can consider myocardial infarction possibility. So this is about second thing, that is location. Then we have to ask about the associated features. Especially if there is undue sweating or palpitation or dyspnea, then if there is impending doom, and in some cases take the history of vomiting and diarrhea also. So if any of these are associated along with chest pain, we have to consider possibility of myocardial infarction. Vomiting and diarrhea, because especially in inferior wall MI, they might present with these features because of vagal stimulation. So this is about associated features. Then we have to ask the individual to describe the nature of pain. So this is very, very important, because suppose it is sharp shooting pain, and if the individual is able to localize it at a particular point, it is not because of MI, it is due to some other cause. Especially we consider it as pleuritic pain. Then if the individual tells it as burning type of sensation, then we have to consider the close possibility of peptic ulcer disease, which we discuss in detail now. Next, if the individual complains it as compressive, tight compression or some heavy object or something heaviness at the chest, here comes the possibility of myocardial infarction. This we have to remember. And sometimes the individuals will complain that it is deep, and they cannot easily describe it, the leaking type. Here it might be because of some musculoskeletal issues. So these are the things which we have to ask in the history. Then one more very, very important thing is to ask about past history. That is, here for the MI, the closest mimic will be peptic ulcer disease. So peptic ulcer disease. In past history, there might be similar episode in the past which they would have dealt with antacids. So we have to carefully ask them that whether any similar episode happened in the past, similarly like this one, and few individuals will tell that similarly this thing has happened and after taking antacids it got relieved. So you have to be careful there. And as I told, it will last for few days sometimes, not a sudden onset pain, and it will be of burning type often. and there will be associated abdominal discomfort or any particular food intake association will be there. This is in the past history. Whereas, what is the importance of past history in MI? We have to ask about any risk factors for MI. For example, hypertension or diabetes. And one more very important is family history. Family history and smoking, alcohol intake. So these things should be assessed so that we will get to know that the individual is at risk of having myocardial infarction. This is all about history. So to summarize in terms of myocardial infarction, usually it will be, the duration will be sudden onset, short lasting. Location, they cannot localize, so it will be diffuse. Then associated features might be there, and the type description of pain will be usually compressive or some heaviness. Here you can consider Levine's sign also, as the individual will just hold his whole palm and show the site of pain. That is called as Levine's sign. So this is all the history. After that, obviously we have to immediately consider doing ECG. So once we get the ECG done, there might be obvious changes of MI. Changes might be present, or the situation will be, we will be in doubt whether these changes are MI related or not. So in this situation, immediately give loading dose. Loading dose should be given. That is aspirin 300 mg, clopidogrel 300 to 600 mg, usually 300 mg can be given, and atorvastatin 80 mg. And if the individual is having pain in front of us, we have to give sublingual nitrate. So this should be done. This will be like benefit out of doubt. Then we have to consider sending troponin I or T. Any one of these two can be sent, and if it is positive, it will confirm the possibility of myocardial infarction. Then, as we told, if we are in doubt, we have to consider repeating ECG. Repeat ECG after some times, especially like 30 minutes. Then what we have to observe in repeat ECG? Major focus should be on dynamic changes. That is, there were some changes in ST segment or T waves which are continuously changing. So that is considered as dynamic changes. This is very significant. So this is one possibility. Then immediately we have to assess for the duration. If the onset of symptoms, everything is fitting into less than 90 minutes, immediately consider for PCI, primary PCI. If your center is equipped with doing PCI, we can consider there only. Otherwise, please refer the case for primary PCI. Suppose if primary PCI facility is not there, then don't hesitate to thrombolize. Thrombolysis has to be done. So before this, we have to check for vitals. That is pulse rate, blood pressure, and saturation. Because these things are very important. Pulse rate, because we have to monitor for arrhythmias. Post MI. BP is very important in terms of thrombolysis. Then saturation, again related to cardiac vitals. So these things should be checked and immediately consider thrombolysis. See, here many drugs are available, but if the individual is poor, not affordable, and if you don't have much experience in thrombolysis, always consider streptokinase injection. So what you have to do? So streptokinase 1.5 million units. 1.5 million units should be diluted in 100 ml NS, 100 ml normal saline, and infused over 45 minutes to 1 hour. Slow infusion has to be done. In this case, every 10 to 15 minutes, monitor for blood pressure and pulse rate. So this is very important. Every 10 to 15 minutes, monitor BP especially, because there might be chances of fall in the blood pressure. So after this 45 minutes to 60 minutes, after completion of the infusion, there will be improvement, and this will help a lot to many individuals, so that the major thing is done at the beginning only. Then we can advise the individual for undergoing further procedures if required. So this will save life in many cases. Don't hesitate to thrombolize. So that's all about chest pain. To summarize, whenever we get an individual with chest pain, first thing which we have to rule out is myocardial infarction. So for that, in history, immediately ask about the duration. Short lasting, severe type of sudden compressive type of pain, which will aggravate especially on minimal exertion and lasting for a few minutes to hours. And obviously sometimes individuals might tell radiation also. So it might radiate anywhere between jaw to umbilicus. This you have to remember, not only left arm. Then get ECG done. If changes are obvious, immediately give loading dose. And if you are in doubt, then also you can give loading dose, benefit out of doubt. Then we can send for troponin. And whenever we are in doubt, get repeat ECG, so that you have to observe for dynamic changes. If there are dynamic changes, it is significant. Then if the overall duration is less than 90 minutes, consider primary PCA. If the facility is not there, don't hesitate to thrombolize using streptokinase. And the dosage is here only. Only thing is, while doing thrombolysis, monitor blood pressure and pulse rate. So that's all about chest pain. Thank you.